Thank you, Varun, so much for your presentation. And I think that we will very much like to have your publications so we can learn more, maybe put them on Saluderecho for people to see them, and also your presentation. What makes me think about your presentation is that countries try so hard to develop pro-poor policies and pass pro-poor policies. And then something is fundamentally wrong if the judiciary has to come and rule to implement such policies. So there is a lot to do in the systems to make policies work, or either the policies want too much and it's not possible with the institutional structure that in a country exists to be able to implement it. I want to give the floor now to Abdo Yazbeck. He's a lead health specialist working now in Africa, and he has worked a lot in equity and knows a lot about the different policies that countries have tried to put in place, pro-poor policies. Thank you.
Good morning. I'm going to do my presentation in French just to confuse people.
Oh, God.
No, just kidding. It's wonderful to follow the last two speakers because the logic of the presentations makes a lot of sense. I've been an equity advocate all my professional life, specifically in the health sector. So what I've been focused on is how to make health systems pro-poor. The title reflects a frustration of how we use the concept of equity and pro-poor to justify policy. But in reality, sometimes it's just words. It's not reality. And that's what I'm going to focus on very briefly. I only have 10 minutes. In the health sector, we have a problem. We have data now from over 56 countries, middle, low-income countries. And if you add China to the data, which is not that different, it'll be about 4 billion people. And if you compare the poorest to the richest, poorest 20% to the richest 20%, an infant from a poor family is twice as likely to die before reaching age 1 than an infant from a rich family. A child from a poor family is 3 times as likely to suffer from severe stunting, malnutrition, than a child from a rich family. And an adolescent girl from a poor family has 3 times higher level of fertility than an adolescent girl from a rich family. So we have an equity problem within the health sector. Just to give you a sense of regional distribution, this is infant mortality rate across 6 regions, Eastern Europe, East Asia, Europe, Central Asia, Latin America, Caribbean, Middle East, North Africa, South Asia, and Sub-Saharan Africa. Consistently, there's a big gap between the infant mortality rate for the poorest 20%, which is in the blue bar, and the infant mortality rate for the richest 20%, which is in the red bar. In fact, Latin America has the highest level of inequality, the gap between the rich and the poor, even though the health outcomes are relatively better. And we have data for other variables. I just don't want to depress you too much. So this is one of my favorite quotes, and I don't know who said it, so I went to Wikipedia, the source of all knowledge. And there's a debate on Wikipedia as to who said this, and nobody really knows. The quote is, "The road to health is paved with good intentions." And it reflects a lot of what we do. We claim to be pro-poor, and yet when we look at, and I'll show you some numbers, when we look at the allocations to the health sector, it tends to be captured by the wealthy. We claim to want to do universal programs. This is the new term everybody loves now. But in fact, many universal programs are pro-rich, not pro-poor. So just saying universal is pro-poor, not right. And the most recent one, legal approaches, rights. We justify the push for rights, for legal, for constitutional mandates on a poverty angle. But increasingly, we're finding that's not necessarily the case. Varun's analysis is wonderful because it starts nuancing which part of the legal element can be pro-poor, which part is not. So basically, my main message is stop the rhetoric and focus on a very basic empirical question, which is a question that Varun asked. Who's benefiting? It's not the theory. It's the reality, the empirical fact. Who's actually benefiting from policies, whether it's legal, whether it's universal, whether it's allocation. So I said allocations. This is the data from these 56 countries, which again, 2.8 billion people, so this is not a small sample. If you look at basic healthcare services, which tend to be publicly funded, from antenatal care to attended delivery of a pregnancy, consistently pro-rich. The wealthiest capture more of the government's benefit, the subsidy, than the poor. And if you look at the last two columns, mother contraception for women, attended delivery, it's actually the largest gap. So not only does the health sector fail the poor, we fail poor women more so than any other group. And this is the reality of our allocation. This is work from people here at that organized the conference, this meeting, looking at litigation cases in Colombia compared to the Human Development Index in the different parts of the country, again showing that the higher level of litigation tends to happen at the higher levels of a Human Development Index. The way the legal system is being implemented appears to be pro-rich and not pro-poor, and there's data from other countries, Brazil and others. Finally, I want to tell you about my work on making health systems pro-poor, and this is based on data on work we did when I was at the World Bank Institute, and it's in a book that's translated into Spanish very badly in Colombia, I understand. I don't know why. When I showed it to Maria Luisa, she almost cried. It was so badly translated. But these are countries in which we actually asked the question, who's benefiting? And we only selected countries where we had success, where an implementation of a health policy actually produced a decrease in inequality. And that is the empirical evidence that the policy made it less pro-rich, made it more pro-poor, decreased inequality. I don't have the time to go over it, all of it, but the book is available. It's free, even with bad Spanish. The French version is better translated, and the Russian as well, but the Spanish is terrible. The way we think of the health sector, we think of 4 control knobs, things we can do something about the policy with: financing, payment, organization, regulation, behavior, which impact intermediate outcome, which impact the final outcome. So I organized the findings around 6 rules of thumb. I'll just very quickly run through them and just tell you which countries we found evidence of success. The first one is on financing, is how do we generate revenue for health? And the rule is de-link the use of the services by the poor from them having to pay. And you can do that in several ways. You can increase insurance coverage for the poor, a la Colombia, Mexico, and others. Or you can increase coverage of insurance through community services, a la Rwanda in Africa. Or you can cut the fees they have to pay, exempt the poor from paying, what happened in Indonesia and Cambodia. The second one is allocation, make the money follow the poor. One of the biggest problems in health is the money follows the facility. So if the money follows the facility, and the facility is placed in areas where the poor don't have access, physical or otherwise, it's going to be pro-rich. So examples in Chile, in Mexico, Kyrgyz Republic, Brazil, of examples where actually money follows the people, not necessarily the facility. Provider payment mechanism. Hospitals, doctors, nurses respond to incentives. So an important issue is to link payment to by the use of the poor. Actually, you get paid more if you serve the poor. And one of my favorite examples in Brazil, during the implementation of the family health program, actually the payment to the municipalities increased if they recruited more people from the poorest. So actually the incentive structure was to recruit from poor people. In Cambodia, it's actually the hospitals get paid automatically if they serve the poor. Change the incentive structure. Organization, and here was the benefits package. We talked about the legal issues. Are we defining benefits packages that serve the poor? And are these legal challenges ruining that benefits package? And here where I worry about legal challenges messing up what could be possibly pro-poor policy by moving money away someplace else. What Varun said is we don't know how that's affecting the system. Actually, we're starting to find, with lots of legal challenges and getting money to low cost-effective services, you are losing money from cost-effective services, which tend to go to the poor. Regulation, giving voice to the poor, because they don't have market power. Can we give them voice power? And there are ways of doing that. And persuasion, closing the distance on the demand. We have to remember one of the reasons the poor don't seek care is either knowledge or cultural in nature. It's not just the system. So we have to address this knowledge gap and them demanding care. It's not just about supply, it's also about the demand. Finally, the reason I get frustrated is people use the term poverty or equity to justify a lot of simple things, simplistic things. But poverty is contextual and persistent. North Mexico poverty is different than South Mexico poverty. North India poverty is different than South India poverty. And it's persistent. So simplistic answers will fail. Cut and paste, cookie cutter solutions will fail. Slogans, whether it's rights, universality, will likely fail and actually may be damaging. The answer is actually derived from understanding the real concept. If you look at all these positive examples I showed, one of the most important messages, they actually listened to the poor. They identified where the problem is. And then the solution followed that. And then you design programs to address these constraints. But you adjust them to institutional capacity. What you can do in South India is different than what you can do in North India because the capacity in South India is much stronger. So you have to adjust your answers to the country capacity to resolve it. And again, keep asking the question, who's benefiting? If you don't ask that question, we never can get it done. Thank you.